Good afternoon. My name is Brian Reif, and welcome to today's Activity Strong webinar, Understanding the Proposed Final Rule, Minimum Staffing Standards for Senior Care. For today's webinar, we are providing one free NAB, NCAP, NCCDP, NCTRC, and NZSRTD CEU credits. And to be eligible for these credits, you must remain on the webinar for the full hour. At the end of the webinar, I will provide the required post-webinar CEU survey evaluation link. It will be posted in the webinar room chat box, and it will also be sent by email this afternoon. So please make sure that you check your junk and spam folder for that link. If you have any questions, please email us at webinars@linksenior.com. And the CEU certificates will be issued by email before the end of day on Friday. Again, please make sure that you check your junk and spam folder for the CEU credit. Thank you, and I'll turn it over to Charles.
Thank you so much, Brian. Welcome, everyone. Sherry, thank you so much for joining. I'm excited for our conversation. I'll get to have the pleasure of introducing you deeper in a few minutes. But like I said, welcome, everyone. This is our September 17th, 2024 Activity Strong webinar. And to give you a little bit of background, Activity Strong was started by Link Senior in partnership with great organizations that include Activity Connection, NAP, and NCAP. And, obviously, I don't want to, quote unquote, steal the thunder or talk too much about staffing because Sherry's going to do an amazing job. But one of the things that we aim to do with Activity Strong is to start with what we believe to be the essential part of senior living, which is life enrichment activities, and then connect it to a very important topic. And as we will further understand today, obviously staffing is a big source of discussion these days. Quick company updates. If you have not heard the news, I'm very excited to share with you that Link Senior was acquired, merged with an amazing organization called LifeLoop. And, nothing changes for our clients, and we're building this best of breed approach to resident engagement. Today, interestingly enough, marks the 2-month anniversary of that merger that was announced on July 17th. And I can't tell you how excited I am, to continue furthering the resident experience in our industry. Quick introduction about myself. I started in Senior 17 years ago. I'm actually an activity director. I went through MEPAP 1, so yay to activity directors out there, especially the ones that are certified. And if not, obviously, please consider it. But two things that are very important about myself and some of the things that are driving our organization is we love activities. We believe that they are essential to senior living, which is one of the many reasons why we are investing in so much in empowering professionals, educate them, and just acknowledging the amazing work that's being done there. The other thing that's very important to us all is this notion of, quote unquote, old people are cool, with the idea that everyone is cool, including older adults. And if you have any questions on that, feel free to reach out. Link Senior itself, up until the merger, we touched the lives of 50,000 residents with amazing organizations spanning from lifespan community, senior living, and long-term care. And as I mentioned, we are honored to continue this work in empowering you all to engage your residents through the use of technology, best practices, and just some of the deepest knowledge in terms of connecting life enrichment and clinical outcomes, some of which was actually shared this in the peer review journal that was published a few years ago. I want to start getting us to our discussion today. So obviously, like I mentioned, staffing is a big topic. We are going to be talking about how we understand the proposed final rule, the minimum staffing standards for senior care. A couple of thoughts on the topic before I hand it over to Sherry is that we, as an industry, are obviously a people industry for people. And it is so important for us as an industry to really recognize the need for quality, qualified team members, but also having a good understanding based on what our residents, our elders need for proper service, proper quality, what is required. So with that, I'm just very excited to introduce you all to Sherry Thomas, who's the Director of Clinical Services with an amazing organization called LeaderStat. And just a pause here to say that we have partnered with LeaderStat on some of these educational sessions before. And if you have any questions about the consulting services, the different types of services that LeaderStat has to offer, I highly recommend that you reach out to Sherry or anyone there. It's one of the best organizations that I know on the particular topic. With that, Sherry, I'll hand it over to you. Thank you so much for being with us, and excited to have you.
Thank you so much, Brian and Charles. I really appreciate it. I'm going to just take a moment here to share my screen with you all, and then we will get started on our webinar. I'm so delighted to see such a great turnout. Wow, amazing. All right, so I hope everyone can see my screen properly and hear me okay.
If you don't mind putting it full screen.
Oh, I thought I did. I'm so sorry. There we go. Okay.
Perfect. Thank you so much, Sarah.
All right, sure. All right, and you can hear me okay?
Yes, absolutely.
Okay, all right. All right, so thanks once again. As you know, the topic of our webinar is understanding the proposed final rule for minimum staffing standards. And I know there's a lot of angst about this rule. So in the beginning, we're going to go over some of the technical aspects of the rule. And so it might be a little dry, but bear with me because it's important to have a good grasp of those. And then as we get further into the webinar, we will be talking about some strategies for how to identify your resources, for how to link your facility assessment to your EPP and your QAPI program. That will be more on a practical level. So that will be the best part of the webinar, I hope, for you, and you'll be able to take away some good strategies for dealing with this minimum final rule, or excuse me, the proposed final rule, which I know has caused a great deal of angst for many of you. Okay, so just to quickly go over the objectives, I know that you can see those. We will, at the end of the webinar, want you to understand the proposed staffing requirements, to understand the updated facility assessment component of the final rule, to help you identify resources to meet your resident needs, and then link that all into these programs. And as I just alluded to also link that to your staffing plan, your EPP, and your QAPI. So as I said, let's start by looking at some of the technical portions of the rule. We know that this rule was published in the Federal Register on May 10th of 2024. It does only apply to skilled nursing and nursing facilities, not to AL or IDDD settings at this time. And then there's also a medical institutional payment transparency provision for reporting that we'll talk about briefly. So let's start out with some of the requirements for the HPRD requirements and the RN requirements. And for some reason, I skipped a slide. It bounced over to this one. So let's talk about that first slide with the HP hours per resident per day. So first of all, the resident hours must exceed or meet a minimum of 3.48 for total nursing staffing, including but not limited to a minimum of 0.55 hours per resident day for RNs. And this is on the slide I skipped, my apologies. The director of nursing, as well as RNs with administrative duties, are likely to count toward this 0.55 as long as they are available to provide resident care when needed. So they cannot just be strictly administrative nurses. They have to be able to jump in and provide that resident care when needed. So the next portion of this rule discusses the minimum of 2.45 hours per day for nursing assistants. So the final rule, take note, does not change the definition of nursing assistants, which per the SOM states that nurses' aides include certified nursing aides, aides in training, and medication aides and technicians, which all require training. Now, this portion of the rule is really important to take note of. And remember that you cannot staff only to just the numerical standards. Sufficient staffing is really in the eye of the beholder. So what you might think is sufficient staffing, perhaps your resident doesn't, or their representative doesn't, a surveyor doesn't. So you have to ensure not only that the numerical standards are met, but that you have sufficient staff with the appropriate competencies and the skill sets to assure that you are attaining and maintaining the highest practicable physical, mental, and psychosocial well-being of each resident, which we've all memorized from years past, that is our goal, always to attain and maintain those parameters. As determined by your resident assessments, acuity and diagnosis of your resident population in accordance with the facility assessment. So you can see where the facility assessment is really going to be the backbone of getting this rule adequately implemented. I have included a chart for you that outlines the implementation timeframes. Do remember that the enhanced facility assessments requirement has already taken effect. That came into effect on August 8th for all facilities. 24/7 RN requirement, May 11th, 2026, May 10th, 2027 for rural facilities. Total minimum staffing standard, May 11th, 2026, or May 10th, 2027 for rural facilities. And then your individual minimum staffing standards, May 10th, 2027, or May 10th, 2029 for rural facilities. So there's a staggered implementation of this, but please remember that the enhanced facility assessment requirement is already in effect. So you should be well into meeting that requirement. So we're going to talk a little bit more in depth about the facility assessments required, the technical portions, and then, as I said, we'll get into some of the sort of the meat and potatoes of the strategies. So CMS decided to emphasize the requirement for this new facility assessment focus by moving it into its own section in the Code of Federal Regulations. So you have that code number there. And the emphasis is really on going beyond the minimum. If you remember when the facility assessment requirement first came about, the facilities really sort of did a template and just put together what they thought would meet the requirements. The surveyors may have glanced at a little bit, but they didn't go into any depth when they reviewed your facility assessment. That has all changed. And the goal of making these changes with the facility assessment is to, again, link your programs so that they all have a good flow, and also to make your facility assessment, your EPP, your QAPI program, a living, breathing part of your day-to-day culture. And then further, to make that very clear as to how you will affect changes when you have some type of an emergent situation. So it's not just a paper that we did for compliance. And I know that's sort of how it started, but really this rule tells us that the expectation is that we go beyond the minimum. The previous rule that we had did not specify who had to participate in the resident assessment process, but it did make some recommendations. The updates to this regulation do require that active participants are listed. And so some of those participants would be your facility management, direct care workers, and their representatives. And we'll talk about the representative portion of the workers here in a moment. And while the residents and families are also listed under active participants, the regulation tells us that the facility is only required to solicit and consider any input they may provide. It may not be practical for us to implement these ideas and input, but we do have to solicit and consider the input. So you must have a process for ensuring that that occurs. CMS did finalize the facility assessment as a standalone section in the CFR. And once again, that location is outlined there for you. Various sections of the ROP were also updated with reference to that new location. And facilities had 90 days to implement updates to the facility assessment, being mindful of that August 8th implementation date. So what are some of these changes aside from who has to participate actively in the assessment and that it goes beyond the minimum? Well, we must use evidence-based, data-driven methods for the care required by the resident populations. And what I have seen over the course of my career as a director of nursing, as a consultant, and going into many buildings throughout the country is that historically we have done a very good job of gathering data. We gather it, we take it to our QAPI meetings, we talk about it, we report the data, and then we put it all in a binder in the minutes, and we sort of many times put that binder on the shelf, never to be looked at again until the next quarterly QAPI meeting, which is usually how they're scheduled. So it doesn't happen in all cases. And I'm certainly not saying that we've all done a bad job, but we just haven't really been pushed, I don't think, to do something with this data. So this requirement is going to encourage us and give us that extra little push to make the data something that is important to our improvement processes. And I'm sure that many of you have already started that and you have some good methods in place. And this is just one little additional push. We must use a facility assessment to inform staffing decisions. Once again, we have that sufficient number of staff term with the appropriate competencies and skill sets. As you've identified what is necessary for your residents through assessments and plans of care. Now, as far as competencies go, I want to stress that it's not enough to just have some type of a checkoff list for these competencies. Many centers will have a fair, an educational fair, which is great. They're fun. You can get a lot of engagement from your staff during those fairs, but often I will see just competency checkoff list, check, 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 and you're not really validating those competencies. So it's critically important that you do validate those competencies so that when your staff is questioned about their skill sets, what they know, what they're able to do, that they can articulate what they have been taught, what they know, how they understand their job description and the requirements of their job. It's also becomes crucial if you have some type of an adverse event in particular, and you need to show that you have validated competencies, that will become crucial in your investigation of that adverse event. The facility assessment also must look at specific staffing needs. So not just an overall staffing plan, but looking per shift, looking at weekends, and adjust it as necessary based on any changes in the resident population. In some instances, I know that staffing model is sort of static. It needs to be more fluent and change as changes occur in your resident population, and as you have contingency plans that you need to put in place. The assessment must also address residents with various diagnoses, including your behavioral health needs, along with the services you're providing to them. And I would venture to say that most of you have already been doing that in your facility assessment, but this just moves it to a more comprehensive level. Your facility leadership and management must be actively involved in the process, and I'm sure you are if you're in those positions. And those management and leadership positions include, but they're not limited to, a member of your governing body. So you want to ensure that you've identified who your governing body is. That can get a little tricky sometimes in your smaller centers where it might be harder to identify, but you need to identify who is your governing body made up of, and they need to be involved in the process. Your medical director, administrator, of course, DON, and direct care staff and representatives of the direct care staff if available. So we said a few slides back that we would talk about examples of representatives of your direct care staff. So there's a whole host of representatives that could be included. Might include third-party elected local union representatives, if you have those in your center, business agents, safety and health specialists. You might have a non-union advocacy group for your employees, community organizations, local safety organizations, or labor unions. So those are just some examples of some of those representatives that you would want to include in the assessment. Also keeping in mind, if you have specialized units, if you have behavioral health unit, memory care, subacute, ventilator, trach dependent, CMS, of course, encourages the inclusion or input of staff from those units. And I would venture to say that you're already doing that for the most part. You must solicit and consider the input from your residents and their representatives. We already talked about that in a previous slide. Again, you may not be able to implement it due to practical reasons, but you do need to solicit and consider their input. You need to use your facility assessment to develop and maintain a plan on how you're going to maximize your direct care staff recruitment and retention. And I know this has caused a lot of anxiety because it is an area where we quite frankly struggle to recruit and retain staff. Of course, the COVID pandemic did not make that any easier. In fact, it made it much, much, much harder. So you have to make sure that you are documenting all your efforts for staff recruitment and retention, and really show a good faith effort. You're going to hear that good faith effort term later in the webinar, that you're showing that good faith effort to manage your recruitment and your retention. You also want to ensure that your facility assessment includes planning for events that don't rise to the level of activating your EPP, but they do have potential to affect resident care. So it's important to do, of course, to address the planning for events that rise to the level of your EPP, but it's also important to include these other types of situations that may affect your care. So that could be problems with your availability of direct care nurse staffing, other resources that you may not have available. So please be sure to include that. That is sort of a more nuanced part of this final rule that some facilities are not currently including in their facility assessments. So there are some waiver options and requirements available, and we're going to talk about those and some of the caveats about those. So for nursing facilities, there is a option to waive the requirement to provide licensed nurses and a registered nurse on a 24-hour basis with the following conditions. The center must demonstrate to the satisfaction of the state that facility has been unable to, despite your diligent efforts to recruit appropriate personnel. And what I would recommend here with all of these options and requirements is that you consider designating someone on your staff who is very detail oriented, good with thorough documentation, so that you can keep all of these efforts that you're doing for recruitment, retention, satisfaction of your residents and their representatives, that they can keep that up to date, up to the minute, available, ready to go, tied up with a bow if you need to produce that information. In addition, the state may make some change. They will ask for some additional information for these waiver requirements. And I apologize, but my computer is jumpy, and we did skip one more slide here. So I'm going to read to you slide 19. The state may determine that a waiver of the requirement will not endanger the health or safety of the individual staying in the facility. That's a must. That's a given. The state also will look for any periods in which licensed nursing services are not available. In that case, a registered nurse or physician is obligated to respond immediately to phone calls from the family. And now, moving on to slide 20, the waiver is subject to an annual state review. In granting or renewing a waiver, the facility may be required to use other qualified nursing personnel. And the state agency granting that waiver will provide notice to the long-term care ombudsman in the state and for any protection and advocacy systems that you may have in your state for individuals with mental disorders who are eligible for these services. And the center must notify the residents and your representatives, their representatives of the waiver. For skilled nursing facilities, there's a waiver of the requirement to provide a registered nurse for more than 40 hours a week. And this alludes to the fact that the facility has been required to have an RN on site 24 hours a day for 7 days a week. This applies to those facilities that are located in a rural area and the supply of services for skilled nursing is not sufficient to meet the needs of the individuals residing in that area. Again, the requirements is that the facility either has only patients whose physicians have indicated it has to be through an order, a routine order or admission order. So it has to be documented that they do not require RN services or a physician for a 48-hour period, or arrangements have been made for a physician or an RN to spend time at the facility as a physician determined to be necessary in order to provide those necessary skilled services on those days when the regular full-time RN is not on duty. And I recognize that these waiver options and requirements and this entire rule is very wordy. So you certainly may need to go back and reference some of these slides just to make sure that you have everything covered in the event that, particularly if you need some type of a waiver. The secretary will provide notice once again to the ombudsman and those protection and advocacy systems for individuals with IDD mental disorders. You must again notify your residents and representatives of the waiver, and it is subject to an annual renewal by the secretary. Additionally, there are some hardship exemptions available, and this part of the final rule tells us that one or more of those hours per resident day requirements may be exempted for facilities who are non-compliant. You may not request a survey specifically for the purpose of granting an exemption. Those exemptions are granted for the length of time until your next standard survey, unless there was some type of an exclusion criteria that you fell into. And you must be able, for these hardship exemptions, to demonstrate to the satisfaction of the state that the facility has been unable, despite those diligent, good faith efforts, to recruit appropriate staff. And that's where that very good, thorough documentation comes in. Other criteria for this exemption is that the workforce is unavailable, and that is defined as a minimum of 20% below the national average. The facility must document financial commitment to staffing. And how do you go about doing that? How do you show that you have a financial commitment to staffing and that you're making a good faith effort to hire and retain staff? Well, you have to show that you're offering at least prevailing wages to recruit and retain pertinent personnel. And you can show that through job postings, vacant positions, wage comparisons, any proof that you have that you are working very hard to hire and retain sufficient staffing. You want to gather that all together so that you have that readily available. You must post your exemption status in a prominent, publicly viewable location, which is easy to understand for all your residents. You must inform each current and prospective resident. Don't forget about the prospective residents. Sometimes we do, along with your ombudsman, of your exemption status, as well as the degree to which you are not in compliance with those requirements, those HPRD requirements. So it's not enough to just say that we have this exemption status, but you have to show the degree to which you are not in compliance. The list of facilities that are granted exemption from this rule and the extent to which they do not fulfill the requirements will also be posted on Care Compare. And you would be excluded from these exemptions if you have any of the following situations. If you fail to submit your PBJ data according to redesignation, if you are a special focus facility, if you have been cited for widespread insufficient staffing that has resulted in actual harm, or if it's cited as an IJ, within the 12 months preceding the survey during which the facility's non-compliance is identified. So you're going to have to be aware that you may not qualify for these types of exemptions based on this exclusion criteria. So we've talked about what's in the rule. Let's now move along to how does CMS plan to enforce the rule, and what are the remedies for non-compliance? So in the final rule, CMS touched on the enforcement and remedies, but they did not provide specific details on how non-compliance would be determined. Some of the information that they did put forth are included here. One is that they may impose termination of your provider agreement, denial of payment for new admissions, and or civil money penalties. It will remain to be seen how that's going to actually come into effect. The remedies, of course, include all those available under the enforcement of compliance for long-term care facilities that have deficiencies. The portion of the Code of Federal Regulations that where that is cited is listed there for you as well. They will publish more details in advance of each of the implementation dates. So as we get closer to those implementation dates that were on that chart earlier in the webinar, we should be seeing some specific details about the enforcement and the remedies. CMS will display its determination of compliance with the standards we already set on Care Compare. And once again, we already spoke about that you would be required to post a notice when you are out of compliance with the standards and the degree to which you are out of compliance. So everybody also wants to know about the financial implications of this rule. So let's move along and talk about some of those projections and implications. So there's a gap, some little bit of disagreement between CMS and ACA As to the total cost estimates, CMS is projecting $43 billion over 10 years, or $4.3 billion a year in total cost. ACA a bit higher at $6 to $7 billion per year. Now, these next points are areas which, again, have caused a lot of anxiety for the centers as to how is all this going to be paid for? How is it all going to work from a financial standpoint? So there are currently no provisions requiring Medicare, Medicaid, or other payers to increase payment rates to the providers for any of these rule requirements. CMS does not estimate how much of the cost would be passed on to payers or how they would be covered, except reducing margin or profit subject to current margin, reducing other operational costs, and increase prices charged to payers based on the ability to negotiate prices, none of which seem real attractive, to be honest. And ability to negotiate can be all over the place as to what ability payers and providers have. CMS expects the Medicaid share of cost is 67% for Medicare, 11%, and other is 22%. Estimates assume that both RN and nursing assistant wages will grow annually at 2.31% due to increasing demand for direct care staff. How accurate that estimate is, we just simply don't know and won't know until we go forward. CMS also estimates that the resident population will be stable over the next 10 years, and they're quoting evidence that, as we all know, the resident population is declining. A lot of that as a result of the COVID pandemic. But we also know that we have an increase in our aging population. So the cost estimates could be lowered if the population continues to decline, the resident population continues to decline, but it could be higher if patterns change. So that is also to be determined. CMS also does tie into this rule some requirements of the Medicaid access reporting and payments. So there is specific information included in the final rule that you may want to refer to. These new payment reporting requirements apply regardless as to whether your situation is fee-for-service or managed care. And it does address a link between sufficient payments being received by the institutional direct care and support staff and access to the quality of services received by Medicaid beneficiaries. So there's a link between the payments and the quality, and hopefully the two do meet in the middle. Okay, so we've really reviewed the technical components of the final rule. Again, I know for many of you that was a review and perhaps not the most exciting information you've ever received in a webinar, but very necessary, I think, so that we're all understanding of the basis of the rule. So let's move on now to some of the more interesting parts of the webinar and help you identify how you can implement some strategies to make all these programs have good continuity and linkage. So first, let's talk about how you can go about identifying resources for your resident needs. Many of these I'm sure you've already thought of, but hopefully there are some that you haven't or that you may want to look at in a little bit different light. So you want to start by reviewing and updating the following for inclusion in your facility assessment. And most of these you've already included in your facility assessment, but we're going to try to take it to a little bit higher level. So look at all your buildings, your other physical structures, vehicles. You want to include your owned and non-owned equipment, as well as preventive maintenance requirements. Sometimes I don't see the preventive maintenance requirements included in the facility assessment. So you want to make sure that you add that, because you will need adequate resources to ensure that that maintenance is conducted. Review and update your equipment, both medical and non-medical. Also include how the equipment use is overseen, as well as the maintenance staff training requirements. When we talk about staff training requirements and competencies, we tend to focus a lot on nursing, of course, which is necessary, but you have to make sure that you branch those training requirements and competencies out to your other staff. So this is a point that some of you may not have previously included in your facility assessment, so you want to ensure that you have done that. What services are provided? Sure, you're already doing that in discussing your rehab therapies, pharmacy, and maybe behavioral health services, counseling services, other services that you have available. Make sure that you're including those people who are under contract, volunteers, if you have them, and making sure that those personnel have appropriate education and competency checks. Take a look at your contracts and your third-party agreements for both your day-to-day operations and during emergencies. And this is an area where, when I'm reviewing facility assessments on site in a facility, I often will see that these contracts and agreements are very old and they have not been updated. And sometimes some of the contracted providers are no longer in business. So take a good look at those contracts and those third-party agreements, make sure they're up to date, and keep up with that, because we know that things can change quickly. Use your organizational chart as part of your facility assessment to help you identify resources in terms of staffing and other needs. Take a look at your ratios. I'm sure you're already doing that. Your recruitment and retention efforts. Take a little bit of a deeper dive into the roles and responsibility of each of the departments. And what I recommend is you go through your organizational chart and look to see, do we have clear roles? Do we have clear responsibilities? Do we need to tweak these, update them, what have you? Of course, looking at your nursing structure, number of staff, including your agency and contract staff. Break it down, a number of staff per shift per unit, and then delve a little further into the individual staff assignments and the systems to ensure continuity of care across all shifts. Sometimes we don't do that. We list the assignments, and as residents are admitted, discharged, maybe now that particular assignment that was manageable has now become a bit more unmanageable because you've admitted a lot of dependent care residents, high acuity residents to that one particular assignment. So take a look at individually your staff assignments and those systems and adjust those as necessary, including your day-to-day and contingency staffing. You want to also take a look at how those staff assignments and systems are coordinated. Are your competencies and your training specific to meet the needs of your identified resident population? So for the resident population that you identified in your facility assessment, including acuity, do you have the appropriate training and competencies? Sometimes we rely on the required regulatory training and we don't branch out to meet those specific needs as we identify them in the facility assessment. So you want to make sure that you're linking that. Your competencies should be job specific. And once again, I said this earlier, but stressing that you validate them. Take a look at not just the structure of your departments, but delegation. And do you have the appropriate resources in terms of staffing and the appropriate people to be effectively delegating? And this is sort of repetitive, but number of staff per shift and the assignments. We've already talked about the training and the education needs. For your nutritional services, take a look to see if you have residents with religious preferences, cultural, ethnic. I'm sure you have several residents with special dietary needs. You want to also include your emergency food requirements when you're looking at your resources, keeping in mind that we are a diverse population, and so some of those religious and cultural and ethnic preferences can change over time. As they do, you want to update your facility assessment and update the resources that are necessary for your nutritional services. Some additional items that you may look at to help you identify resources that you need would be your facility-based and community-based risk assessment using an all hazards approach. We're going to talk about that more in detail in just a moment. Your MDS reports, quality measures, really learn how to affect your quality measures. Take a look at them, grab onto that low-hanging fruit that you can improve upon to improve your quality measures. Keeping in mind that the data lags behind, so it's going to take some time to see that movement. But I really urge you, if you don't really specifically understand the quality measures, how they work, how you can manage them and affect them, I would encourage you to obtain some additional information and training on that. Of course, your roster, your sample matrix reports will help you identify additional resources as well as your PBJ reports. And I'm sure that many of you have some really great in-house design reports that will help you identify these additional resources that you need as well. Don't forget about your policies and procedures. Take a look at those and do they really effectively address your resident needs as outlined in your facility assessment? Sometimes we use those canned kind of cookbook PMPs and we don't really update them, revise them to reflect the current population of our residents. So take a look at those PMPs and see, have they been reviewed and revised as necessary, at least annually and as needed for changes. We do a pretty good job of that annual review and we sign off on it. But when we have changes in our resident population, are we adjusting those policies and procedures? So I urge you to look at those more closely and make them work for you. Your technology and your electronic medical record resources, of course, will help you identify additional resources that you might need. Your facility assessment should list all those resources as to how you manage your records electronically, and if you have paper, how those are managed. You must include a description of how you will securely transfer health information to another level of care for a routine resident transfer or discharge, or from an emergent individual situation, or if you have some type of a disaster. And then include how your downtime procedures are developed and implemented, as well as how residents can request records in the timeframes that are required. For your downtime procedures, make sure that is clearly communicated to your staff. Many times when I've spoken with staff members and I talk about downtime procedures, I ask about what they are. The staff is not able to articulate that. And so it's really important that not just the managers understand that downtime procedure, but that your staff does as well. And we can never, ever, ever forget, and I know that you don't because it's always on your mind, infection prevention and control resources. So take a look at how your infection prevention and control program is evaluated. We've done that for years. We've reviewed it annually, but we know that COVID caught us unaware. And so we want to be always on the lookout for emerging infections. If you have changes in the type of infections that you're accepting or caring for, you need to update your infection prevention and control plan and look at any additional resources that you might need in order to safely provide that care. Include your systems for preventing, identifying, reporting, controlling, and for communicable diseases. Don't forget, once again, about those emerging infections. And there's so much information on these potential emerging infections. So I urge you to really keep up with the CDC and public health advisories as it relates to those type of infections. Include how the resident staff, volunteers, visitors, and other individuals are following accepted standards of practice. So how do you go about linking emergency preparedness to your facility assessment? Take a look at your hazard risk assessment. Your EPP plan needs to consider the input analysis from your assessment, and ensure that you have reviewed and updated your EPP at least annually, and as pertinent changes occur, take credit for the hard work you're doing. You must use an all hazards approach that's specific to your facility. So are your hazards tornado? Are they earthquakes? What are they? And include those hazards and how you're going to manage those in your facility assessment. What's your ability to obtain supplies and resources both before and during a disaster? And remembering that an annual review is not always enough. You have to do that when identified risks occur or change. So some of the tags that the survey team will be looking at, just for your information, as it relates to this rule, would be 636, comprehensive care plans, nursing services not related to behavioral health, 741, nursing services specifically related to behavioral health, 801, qualified food and nutrition staff, 826, specialized rehab, 839, staff qualifications, 837, governing body, and of course, 865, QAPI. So how do you link your QAPI program? Well, it has to be a living, breathing program. I already said that earlier on. So how are you going to identify and correct quality deficiencies? You must utilize an ongoing, organized method of conducting your operations, and you have to have a description of your QAPI processes in your facility assessment. Make sure you're updating those to show a good faith effort to continuously improve. And just remember that it used to be sufficient really to do those quarterly QAPI meetings, but because everything's so fast paced and we're really doing deeper dives into the facility assessment, the resident care needs, and the resources, I would urge you to consider doing those QAPI meetings a bit more frequently. And if you have some type of an adverse event, make sure you're doing an ad hoc meeting that gets to the nuts and bolts of what happened with that adverse incident, what you've done immediately to correct it, and how you're going to go forward in continuing to correct that situation. So that concludes my portion of the webinar, except for questions. And there are some resources that are listed at the end of the presentation.
Thank you so much, Sherry. And actually, that was one of the questions: is will we be sharing the handout? And the short answer is yes, absolutely. Sherry, many questions, many great feedback, many thank yous actually right now in the chat. I was curious. So we've seen this as a quote unquote long coming event, right? These changes. And I know that is, in grand part what you spend your time these days handling. From a leader standpoint, not saying that I would start today, because technically I should have started, yesterday and before, but when you engage with homes, I'm curious, how long are your projects? And how, if we were to start today, how quickly can a typical nursing home be brought up to speed?
Okay, so it depends on this situation. We do customize our plans and our engagements based on facility needs. So if it's, a mock survey, of course, that's going to look at all the different F-tags and take longer. If we're focusing in on this final rule, the facility assessment, all the linkages, it will also depend on the facility, the size, the resources. So, the facility assessment piece, of course, is the urgent
Yeah.
matter
Yeah.
since that's is already in effect. So, I think in a 1 or 2 visits, we would be able to really outline where we see gaps in the process through a gap analysis. And then more importantly, any consultant can go in there and tell you where your gaps are, but how do we help you close those gaps? So,
Of course. Yeah.
helping, developing a plan, performance improvement projects, providing additional resources, whatever we can to help you on that path to getting where you need to be to close those gaps. And then we can generally do that 1 or 2 visits, and then a follow-up at sort of designated timeframes that will work for you. Some of that can be done remotely rather than on site. So a lot of that's dependent on each individual situation, but that's sort of a ballpark of what I would project.
I appreciate that. Thank you so much.
Sure.
We had a question that came up quite a few times, and I'll just read it up to you. Obviously, given the audience, I knew was going to come, but let me ping the first one. Tasha, for example, and many others were asking the same question, but the question is, does non-medical personnel, such as activity directors and assistant, count towards direct care? And any more details if you could share on that.
Not in terms of the nursing hours. If you have an activity employee who is a certified nursing assistant and they're doing some direct care, but you have to be able to show that they're actually doing that and they're not in an activity. So yeah, it would be nice because we've got this staff that's very capable of doing a lot of things, but no, you can't.
Yeah. And just a side question on this, can a nurse manager be considered the same as a Don in respects to these?
Yes, but if any of those administrative personnel are going to be included in that direct care, those direct care hours, of course, they have to be able and doing direct care. So you have to be careful about, I know a lot of facilities want to kind of put those administrative nurses in, but you have to make sure that you're meeting those requirements.
Yeah. And sorry, just one question that just came in.
Sure.
Staffing can be different in varying states and for acuity levels. Would the new CMS staffing per patient per day be the same in all states, or are they going to be different from state to state?
It is a federal requirement rule. So if you, of course, the guidance is if a state has a more stringent rule or regulation, then the more stringent would be followed. But I would venture to say most states are not going to take that leap and make anything more stringent than what you all are already dealing with. So it is a federal requirement, so it would be following those federal guidelines.
Great. Shari, I wanted to thank you so much for this amazing webinar. Again, quite a few tens of 20s of thank yous in the slide that I don't know if you had the time to see them. But it's a pleasure again to collaborate with LeaderStat, an amazing organization, and obviously collaborate with you, Shari. So thank you so much for that.
Oh, thank you for having me. I've really enjoyed it, and I'm so happy to see so many participants, and I hope you can have some good takeaways.
Thank you so much, Shari.
Okay.
Everyone, in a couple last minute, actually, in the one last minute that's remaining, I want to invite us all to our next webinar. Interestingly enough, it's still in the topic of staffing, but with a very different angle. We were slated to have an amazing speaker called Jean Harnett, the founder of Radical Sabbatical, early in the year, and she actually lives in Nebraska, and she had tornadoes on the day of the webinar, so she couldn't be with us. But we're very grateful to have her come again, and she's going to be talking again about staffing, but from a different angle, which is the idea of employee well-being and how leaders can invest in obviously their most valuable resources, which is their organization, their team members. So feel free to join us, register today. That's on Tuesday, October 1st, same time, 1 p.m. And I'm going to put again the link in the chat. So feel free to join us. And just as a note, we're now almost done for the end of the year in terms of webinars. and we will be posting them starting next week, I believe. So again, Sherry, thank you so much. I completely forgot to acknowledge your amazing halo
Oh,
around you.
I guess that helped. That helped me through it.
Thank you so much. Have a great afternoon. Thank you all for joining. Take care.
Bye.
Bye-bye.